Hello, I'm Ileana Pina, more recently from Thomas Jefferson University, and this is my blog. I'm thrilled here we're together in person at the American College of Cardiology in Washington, D.C. It's been a good 3 years that many of us haven't seen each other, so it's been really wonderful to see my colleagues and friends. And in fact, I have one of them here with me today, Dr. Justin Ezekowitz. We've worked together on many projects, including the Victoria trial, including Guided, where we suffered through that whole trial. He is professor of medicine at the University of Alberta in Alberta, Canada. And I want to welcome you to this.
Me, Ileana.
You and I have had so many discussions about the right drugs and the right this and the right that, but you're presenting the sodium trial.
That's right. This was a long trial.
This is something that is one of my pet peeves about diet and how we're telling these patients, you got to take all these drugs. And now there's 4 pillars of care, but you also have to cut down your sodium and you got to read the labels. And then you ask, where are the data? Maybe not.
Well, I think that's the same place I come from, which is, do we have the data to say what I'm recommending is valid?
And push it.
And push it. And also, I think what also stimulated this question was, do we have the data to justify our recommendation? But also, there's a lot of finger pointing and wagging at patients, which is unfair to them and isn't very patient-centered in how we approach it. So
that's right.
Take a step back.
They feel guilty.
A lot of guilt.
Terribly guilty, yeah.
So we came at this question with a very honest approach to say, let's do a pragmatic trial in this area and test this hypothesis in outpatients, so ambulatory heart failure, to see if it does.
Class 2, 3?
Class 2, 3.
Okay.
And we were looking for patients who were at least a month after their hospital discharge from whatever cause. And then really looking at patients on optimal medical therapy. So these are patients already on whatever guideline recommended therapy for the 6 countries we enrolled patients from. Across 26 sites, so a lot of heterogeneity, as you can imagine.
And heterogeneity just by the countries alone, yeah.
Yeah. So Canada, Mexico, Colombia, Chile, Australia, New Zealand. You can imagine that in Colombia and Mexico, the sodium content of the food is a lot higher.
Very different.
Yeah, but what we also realize is even within regions of the same country, there's quite a big gradient. So across Canada, there's a gradient. Across the U.S., north-south, there's a gradient.
Oh, God, yes, most definitely.
Yeah. So we designed this trial very simply. Usual care, which is what a recommendation might be in clinical practice, somebody might have already seen or as a recommendation, versus the intervention.
So that's how you define usual care, whatever the site was doing?
Yeah, whatever they were doing. And what we realized is we often do that recommendation, but things don't change. Patients haven't really, there's no real intervention there.
I think they got it.
Yeah, so they're still eating what they're eating. And so that's why we started off with the average content was around 2,200 milligrams per day of sodium per day. So this is a well-treated population already eating at 2,200 milligrams or so, some much greater and some a little lower. And that was usual care. They were starting off at that point. We randomized.
How did you keep track of what they were eating at home?
So we thought a lot about this. We did the 3-day food records, which are well validated in the dietary literature. And they reflect what a person is actually eating because we're recording it actively over 3 days. And that really helps both the counseling at the site when they're in the trial, but also it allows us to back calculate how much sodium they're eating, potassium, protein, calories.
So you could average how much sodium they were intaking. That's very interesting.
Yeah, so we actually had to go through a fairly extensive exercise to design how we were going to do that and then feed that back to the site.
This is tough. A lot of people have tried to do this.
Yeah.
It's very tough. So what was your intervention group then?
So our intervention, we used a series of menus. Now we looked at this, we took a step back from things like the DASH diet, which were like pre-made meals for people.
Right.
I think that's very good for like a phase 2 like a design, but we wanted this to be pragmatic phase 3
That's
style.
not pragmatic.
No, it isn't. No. So we had a whole series of menus developed by our dietitians, which are very broad and wide ranging. So any of us could eat based on what our region is, what we like.
Nice.
So it's very easy to achieve and simply modified the amount of dietary sodium of that menu. So that actually allowed us for really isolating that one variable, sodium, but keeping all the other things like calories and protein, energy requirements the same.
You have a lot of sub-studies out of this with all that information.
There's going to be a lot of information. We're hoping to really understand just diet in heart failure. Just that alone by itself is just to understand it is important.
How long the study?
For the primary endpoint, we follow people for 12 months. We have a 2-year and a 5-year follow-up for all patients as well.
So you finished the first year, or are you on the second year?
All patients have passed the 12-month mark as of December 2021, and many patients have passed the 2-year mark as well. We have maybe a couple patients who've hit the 5-year mark, but that's a very early set of people.
Right. Total number of patients?
We have 806 patients.
That's darn good. And your primary outcome was?
All-cause mortality,
Okay.
or cardiovascular hospitalization, or ER visits.
So really hard endpoints.
Yeah, we chose all-cause mortality mostly because it does reflect that 80% of deaths in heart
That's
failure
everything.
Yeah, and we also had to think pragmatically. Hard to adjudicate death in the first place.
Also expensive.
Very expensive. And cardiovascular hospitalizations and ER visits, we did adjudicate. We used a standardized criteria. We kept it as cardiovascular because although we in other trials use heart failure hospitalization, this one's a broader intervention. So diet affects more than just heart failure, it affects other disease states. So we wanted to keep it very broad and pragmatic. There's always a trade-off we have to make in every trial.
Well, you make the trade-off and you write it down and you keep going.
Yeah. Well, I'm looking forward to digging into the data because there's a lot of information on the events as well as the non-cardiovascular events that we'll be able to drill down into.
So tell us what you found so far.
The primary endpoint overall was non-significant. The hazard ratio was 0.89.
Whoa.
Yeah.
But it was 11% reduction, no?
It's true, and the conservative interpretation is it's a neutral trial, but there's still an 11% reduction by that hazard ratio.
Of the combined endpoint?
Of the composite endpoint, yeah.
Okay.
There was all-cause mortality individually, not different. Hospitalization, not different. ER visits, not different. There's a signal based on the hospitalizations that it looks like it does reduce hospitalizations, and that had the greatest impact on the overall composite for the primary outcome. For the secondary outcomes, the really interesting parts, which were the quality of life and the NYHA class. So as a clinician thinking NYHA class, we did see an improvement in NYHA class by at least one category in the low sodium diet. The odds of that happening was 0.59, so very
close. Very close. Okay.
So we're very impressed by that change in NYHA class. And then from a patient perspective, using the KCCQ, both overall clinical summary score and physical limitation score was about a 3.5 point difference between the
same as most of the drugs.
Yeah, same or better than many of our drugs.
Yeah, 3 point something. Yeah.
So I think that quality of life difference between favoring low sodium arm is significant, and I think it is meaningful. It's the question of it's a secondary endpoint. I think we have to balance the overall trial. And
you wonder, if the patients are allowed to eat whatever they want, maybe in the usual care group, wouldn't that improve their quality of life? Because they don't have to worry about, what they're eating and counting the sodium.
Well, that was actually at the very beginning of the trial. People said if you make them eat lower sodium, it'll worsen their quality of life. That's
what you would think intuitively, right?
Yeah, and that's what we faced a little of uphill resistance on that. So we measured it, and we wanted to make sure we measured it, and it's the other way around because patients may actually feel better on a healthier diet, whatever that.
They don't realize it until they're there.
Yeah, we have to counter our own intellectual biases there, and sometimes have to challenge them and do the trial.
When are you publishing it, or where are you publishing it?
It's just been published simultaneously in The Lancet as of this weekend, so we're just...
Well, you have it worldwide, so that's a very appropriate journal.
Yeah.
And next what? What are you going to do next with the data?
We have 1,000 secondary analyses to understand this population better. We've already looked across geographic regions. There's no clear signal.
How many women did you get in? I'm going to ask you that. How many women did you get in?
A third of the population was female.
And that's not bad.
The average EF is 36%. So when we looked at the epidemiology, we were close to...
probably some have PEFs in there.
Yeah, we're close to, but not ideal. We wanted it to be better balanced. It's a challenge. We can only control what we can control. We had an excellent, to your point, Ileana, we have an excellent representation of women on the steering committee, at the site level, in the food core lab, in the events adjudication.
Warms my heart.
Yeah, everything across the line was very much focused on making sure we got the appropriate equity and representation.
Well, this is really important because we spend a lot of time, I've spent a lot of time in 30 years saying to the patients, you got to do this. You got to lower your sodium. You got to look at the labels. And in Temple, we were having people actually add up, from what they were eating. And nowadays I say to them, I just want you to cook primarily at home.
Yeah.
Put a little bit of salt in your food, which is essentially a 2-gram sodium diet, and avoid the deli.
Yeah, that's a great recommendation.
And other than that, I want you to take your meds.
Yeah, I think you've got the right approach, which is kept it simple.
Simple.
And my usual simple one is try to avoid anything in a bag, a box, or a can.
There you go.
And for most patients, that can help us frame what they should avoid.
They understand that. Yeah.
And even myself, if I had to take dietary recommendations, I would have to really think about it. And I don't have heart failure, so I don't have that barrier. And so we have to keep.
Or that worry that you're going to get sicker if you
Yeah.
go off, because it's not just, today I'll feel a little sluggish. I mean,
That's right.
Yeah. Very interesting. Well, congratulations. This is really hard. There was a long time ago, there was an NIH proposal for a very strict dietary, taking a look at sodium. And it never passed muster. It never got funded. It was so hard to do.
Yeah, these are very hard trials
and
to
so
do.
expensive.
But they're so important. I mean, this is fundamental to the way we live as we eat food. And so if we can modify this one thing, does it make a difference?
Yeah, so kudos to you. Examine the women separately. You have enough probably to maybe make some statements about it, because since women do control the house and they control usually the kitchen, it would be very interesting to see how they did.
We did actually, I'll tell you what we've done so far. We're going to dive deeper into this, of course, but our initial look was to make sure we did a couple things. Subgroup analysis, as we do men, women.
Sure.
No real large signal there. But on the quality of life, we've done a sex stratified analysis to make sure we weren't missing an important difference in one or the other.
Interesting.
And really not different, but we're going to dig into that a lot more.
Wonderful. Well, keep us in mind for another blog when you've done more, so that we can tell our audience, because this is interesting to the clinicians. So all of you that are listening today can take heart that maybe when you forget to give the recommendations for dietary, maybe it's not quite as important as we all think it is. And if you can keep it simple, the patients may be able to follow better. This has been great. Thank you for joining me today. This is Ileana Pina signing off. Have a great one.